Welcome to the Hazard Class Podcast. This is the podcast where I get to ask my stupid questions of some of the smartest people in and around the world of emergency services. My guest this week is a paramedic and death and grief educator who holds a master's degree in death, grief, and bereavement, and a PhD in depth psychology, which is the study of focuses on the exploration of the unconscious mind. She's the owner and lead instructor of Emergency Resilience, which is a training company that specializes in death notification, CPR-induced consciousness, and something called the Lazarus phenomenon, which I'm excited to talk about more today with my guest, Dr. Alex Jabr. Alex, thanks for joining me today.
Thanks for having me.
Of course, yeah. I'm excited to pick your brain and learn a little bit more about what you specialize in, something that I think that we could all benefit in knowing a little bit more about because, I've seen it be done well and I've seen it be done poorly, and it can definitely change the outcomes for not only the responders, but also for the people that we're supposed to be helping. Hopefully not making their situation that's already dire worse, right?
Yeah.
So as is the format of the show, we open up with our wheel of stupid questions. It's just a reminder that asking dumb questions is good. If you point it at the right people, you can still get some pretty smart answers. So with that, we'll open up with that and see what we get today.
What?
Spin that wheel of stupid questions.
Okay, so let's spin the wheel. It's a real wheel. We will see what we get. So we got this question before and we had no clue what the answer is. You're a lot smarter than me and my last guess were, so we'll see what this goes. Okay. If a piece of gum is 10 calories, does that count just chewing it or also swallowing the gum?
Chewing it.
Well, how many calories is swallowing it then?
Well, isn't it negligible? It's like a real fibrous material and it just passes through. So
it's like
if
insoluble
it goes,
fiber?
Yes. Yeah. That's my best guess.
I don't know.
It sounds right to me.
Your best guess is as good as my best guess.
Yeah, because it's the sugar. It's the sweetness of the
What if it's sugar-free gum?
Then why does it have calories, I guess? Yeah, that's a good point.
I guess I don't know if sugar-free gum has calories, but
maybe it doesn't.
Who chews sugar gum? I mean, what, Hubba Bubba or something?
Yeah.
I feel like any gum is sugarless, right? Like Orbit?
No, you've got the zebra gum. I remember the Bubba Hubba. What about that gum that came in the pack, the Big Chew?
Oh, Big League Chew. Oh,
yeah.
I try to grab my laptop bag. Oh, here we go. Here it literally is. I literally have a pack of Big Red from my laptop bag.
Okay.
This says 2 grams of sugar, 10 calories. But it doesn't make any indication of whether you can swallow or not. Whatever, we'll move on. That's beside the point. But I think I've talked to 2 people about this now, and no one knows. So I think that's maybe problematic, but maybe not. I don't know what I'm talking about. All right, let's get into why you're actually here, the things you specialize in, and I know for sure it's not sugar or sugarless gum. So let's talk about your origin story as a paramedic. How did you get into paramedicine? Why did you get in paramedicine?
I was nosy. I'm still nosy. I just, reframed it to call it curiosity. But I just, as a kid, I was obsessed with ambulances and I always wanted to see what was happening. And one day I had an opportunity. Somebody said, "Oh, you should go become an EMT." And my response was quite literally, "Do women do that?" Because I'd never seen a woman do it. I mean, I was graduated. This was 2003 that the person I was speaking to in my class, he was an explorer with the ambulance company. And that was my question to him. "Do women do that?" And he goes, "Yeah, all the time." And I was like, "All right." And he's like, "Yeah, you go do a semester at a college program and you can be to work right away." And that to me, I know it's very ironic. I have a PhD now because back then I could get a real job without going to college for longer than 6 weeks or 6 months.
Yeah.
And I thought, sign me up. So it was really both just I was entertained by the idea, and it was a quick path to get to work so that I could bypass having to go to college.
Did anyone in your family, like, do you have any person that you saw growing up that was kind of in that career field at all?
No. And anybody that I saw like on the side of the road working on a vehicle crash or something like that, they were never women. They were never anybody that looked like me. So I recognized very early in my career the importance of like that representation, because in my head, even in the year 2003, I thought that wasn't something women did.
Did you find resistance as you tried to do it?
No, not at all. I had a great experience as a woman. I know not everybody does, but in my case, I had a very good experience.
So you then, at that point, you became an EMT. How long were you an EMT before you actually went to medic school then?
I think I was an EMT for about 8 years before I licensed as a medic. I went to medic school in 2010, and then I worked as a medic until about, I want to say 2000. My years get mixed up at this point, but about 2017, I had a pretty severe back injury. And by 2018, I had resigned because I had the surgery several months later. My doctor couldn't clear me back to full duty. And once he finally did, my life just kind of took a different direction. And I was luckily able to stay on track with my career as an EMS educator. So by that point, I had been teaching all the merit badge courses. I was involved at my community college, at a university. I was then working as an EMS educator. So my life just took a different direction. And then once I did get cleared back to full duty, it was December of 2019. And I started putting applications in everywhere. And believe it or not, certain parts of the country, while some were apocalyptic, the others were quite literally the dormancy in call volume was evident, and they were laying people off. So I couldn't get a job in 2020 because there was no, people were getting laid off. So obviously that didn't last because we went through waves with COVID. But I think I just accepted the fate that my life was being redirected, and I never got back on an ambulance, unfortunately.
When you had that injury, what was that experience like? Obviously, you having done this for a decade at that point, working in EMS, what was that emotional roller coaster like as you kind of saw that be stripped from you?
Horrific. I'm glad you asked, though. It's an important piece of the puzzle, because at that point I had spent about 15 years on an ambulance. It was my entire adult career experience. I loved being a paramedic, and I identified with it. It really was a big part of what I did, and I enjoyed doing it. And so it wasn't just the risk of like, what am I going to do with my career now? It wasn't just what am I going to do about income and survive in, taking care of myself, but it was also this, the physical injury. So I had if those of your listeners who are familiar with back injuries, I had the L4, L5, S1 is like your EMS special. And my S1 was herniated to the tune of 23 millimeters, which is significant. Anything over 7, I've been told, gets a surgical consult. And my physician, my surgeon hadn't worked on anybody that had greater than a 15. So to say I was in a lot of pain was an understatement. But what came of it was actually it kind of reactivated some old PTSD from childhood. So even though I felt like I had made it through my career for the most part with your, normal day-to-day stuff, like I didn't have any severe PTSD from one particular call, but all of a sudden I had these really traumatic dreams and night terrors that I hadn't had since I was about 4 or 5 years old. And that got triggered by a physical injury. So there was this realization that my mental injuries could manifest and be connected with my physical ones, and that there really was no uncoupling those two.
So as you kind of processed that, and you shifted gears into this, I'm going to teach, I'm still going to be involved in EMS in this way, you decide to go back to school, right? And then why death and dying? Like, why the macabre, right? Theoretically, right? Most people would see that as pretty outside the box, specializing in that. Why?
In the last couple of years of my time on the ambulance working as a paramedic, I kept getting faced with these very unique calls where the patient wasn't quite dead yet, but they had one foot in the grave and they may have been on hospice and family had a DNR, but they didn't want to give it. And typically in the area that I worked, because, and I know every area is different, but typically if just one family member says, no, I want you to do everything you can, you had to medically intervene. So even though this patient was going home to die and everything about their vitals said that they were in the end stages of death, we had to interrupt that. And I thought to myself, why? Like, this is not okay. This is not, but nobody really taught us how to have those conversations. So I kept getting put in these situations to the point where somebody would pick up shifts with me because they'd be like, oh, what almost dead call are we going to have today? Almost dead whisper kind of thing. And I was like, I just started leaning into it and I started realizing it's not that they want us to save their life, because we've all been there, right? Everywhere I go, somebody has had an experience where family calls 911 for a 99-year-old grandma wanting you to do everything. They're not calling for you to save their life. They're actually calling because they're scared. Mm-hmm. They're calling because they weren't told what a death rattle is. They're calling because they feel guilty, because they feel like they're not doing something because nobody's told them that that's what death looks like. It's not this peaceful, it's a very tumultuous initiation into the end stage of life and transitioning out of this life into the next, wherever that might be for someone's beliefs. And I just started having those conversations with them. And so I thought it was so ironic because in being a paramedic and EMT, I never really said I was trained to save lives. I was trained to prolong death. And then all of a sudden I was learning how to advocate for death. Mm-hmm. I was learning how to help family members create this sacred space, this moment of respect and dignity for death, rather than cracking ribs and tubing them and taking them to the hospital and putting drills in their legs. And I thought, that's so weird. Like, this would have been, and it was rocky at first, but eventually I got better at it because it kept happening. And I just thought, we should have been taught this. We should have been taught how to communicate with the family. And so when I had an opportunity, by the time I was finishing my bachelor's when I hurt my back, and I thought to myself, his writing's on the wall. I might not have a career anymore in EMS, but I think I need to really secure myself and just finish my master's. And so when I looked into going to graduate school, it was either I wanted to get work as a therapist, I wanted to go into clinical therapy, or this program in grief and bereavement was also an option. And I thought, I think I need to study death for first responders. And that's what I ended up doing. I ended up going with the latter. And my entire graduate program was focused around this theme of death and first responders. And that's ultimately what gave birth to the curriculum that you're probably familiar with today.
So what does a curriculum like that for a master's degree even look like? What kind of courses are you taking to specialize in something like that?
So it's a lot of end-of-life care. It's a lot of legal. We're talking like pulse, DNRs, hospice, palliative care, medical aid in dying. You're talking about death traditions, death rituals, cultural differences around death. Death notifications was obviously something that I kind of, like, you'd have to write a paper every week, or you'd have to write a paper, capstone for every class. And every chance I got, let me put this way, the further up in education you go, the more autonomy you have with the topics. They'll give you, like, it went from being in a bachelor's program where you were told to do X, Y, Z, and don't go outside of that. Whereas, when I got into my master's, it was like, okay, you're tasked with blah, blah, blah. They just gave you a lot of creative rights. And so I always came back to, how can I do this? So I did a lot of research. I did a lot of surveys. I tried to piece together what I could. There's very little out there. There was a lot of what went into the original course. The earliest inception of this course was the stuff I learned from hospice care and grief work. So like Kubler-Ross and the 5 stages of grief, and where we've come since that era, because we've evolved to kind of move away from that, but it still offered a lot of fundamental importance.
So then now you go from that master's program to this doctoral program in depth psychology. So I've never heard of that before. Yes. Looking into like your kind of resume. Talk to me about how you got into that, what the heck that is, and how it relates.
My bachelor's was in emergency management. It was just a giant FEMA course. And I got out of that program going, I never want to be an emergency manager. And when I got into graduate school, and particularly being able to pick a topic as interesting as death and everything that goes around it, I thought to myself, well, this is fun. Like if school was as fun as it was in my master's program, in my associates, I would have gone back a long time ago. But by the time you get up there, you don't have to do all the BS courses, like the stuff you really didn't go to school for. Like you don't sign up for a master's program and have to do like an intro to history or something like that. They get right to the point. It's very focused. And I thought, well, why not just go for a PhD? Like I'm already I'm already doing this. I'm already in the mood, in the mode of being a student. And I quite literally Googled weird PhD programs because I didn't want to I just wanted something that was going to keep me interested. I thought if I can find something that I'm going to be researching, because I'm a very curious person. I told you at the very beginning, I got into EMS because I was nosy. It evolved into curiosity. And I thought if I'm going to research this stuff anyways, because I had, been so involved as a mental health advocate at this point, an educator, that why not get a PhD for it? And so I Googled that, and up came Pacifica, which anybody who's ever gone to this program, it's in Santa Barbara, California, they know we kind of nickname it Hogwarts because it's got this just mystical feel to it. And, there's programs there in Greek mythology and somatic experiences, which is like the body movement and feeling and experiences. And my course that I picked was depth psychology, which is essentially everything that you can't see. So you have somebody that is behaving a certain way on the objectable surface that you can identify, or I should say witness, but then what's driving that behavior? What's embedded in the subconscious? What's the 98% of them that's programmed to behave this way? And so depth psychology just digs a little deeper, I guess.
Man, so how do you feel like that informed you in your other studies about understanding grief and end of life, to understand the the unconscious thought processes of the mind?
A lot. It actually really opened up a whole other world, really an underworld of, let's say, for example, like if you were to ask somebody, or you were to ask me several years ago, who the person who was the most wounded, what person in the fire station is most wounded, I might think about the person that's sad or mopey or withdrawn, but it's actually kind of the person that's the biggest jackass. They're not easy to work with. They're angry at everybody. Everything is everybody else's fault. They're the ones that need the most love, and they're the hardest ones to love. And there's these unconscious defense mechanisms that they themselves aren't even aware of because it's too close to them. They can't even see it in themselves. And so it taught me to understand why I judged the homeless, the person that was homeless, or the person that had an addiction. It taught me a little bit more about addiction, that addiction isn't actually about the substance, it's about the pain. They're using it as a coping mechanism, that coping mechanism was used to help them survive something that now turned on them because it's maladaptive, and it then created more problems than it actually solved, and it created this vicious cycle. It taught me about adverse childhood experiences and how that shapes a person as an adult, and how that puts them more at risk for alcoholism, COPD, cancer, depression, suicide, all these things that are all, encompassing of the human experience as an adult. But you're like, wow, that actually stemmed not just from my choices as an adult, but that maybe there's these programming that I had as a kid that has led me to behave this way as an adult, that's put me at higher risk for X, Y, and Z. And so it's all just connected, and we've been getting impressed upon, our psyches have been getting impressed upon since we were in the third trimester womb of our mothers.
Wow. So you go through the doctoral program, and then you have this, is your business already started prior to this, or does it kind of launch on the tail end of this graduation?
I already had it. So I had my emergency resilience is a continuing education platform. I started that probably in 2018. I kind of went live within 2020, and then it just kind of kept growing from there. And I graduated a couple of years ago. So it was kind of concurrently evolving.
So at what point do you kind of hone in on these particular specialties in your continuing education practices? Like where you're like, I want to talk about death and grief notification. I want to talk about, the CPR-induced consciousness, which we'll get to at some point here because I'm interested in that a lot. But was that just kind of like a logical progression as you went through the education and your interest in these subjects, or was there a moment where you're like, this is a hole in the market, I'm going to be the one to talk about this thing?
My intro into creating education on my own was with the intent of doing mental health. And then I do a lot of teaching in person. I had a lot of different topics and courses I had written and presentations I had given. And the one that kept getting the most request was death notifications. And so I thought, well, let me just start with that. And then there was this understanding on my part, from my perspective, that this had a lot to do with mental health, because if we don't prepare people for this thing, they instead either avoid the family, or it sets them up for failure and they feel like they've done something wrong, or that they could have done a better job, and it creates this rumination. And it's just not a pleasant experience. We can't be sending people with type A personalities into situations unprepared and feeling incompetent and think that they're going to walk away feeling good about that. And so that kind of evolved on its own. And other topics that have kind of come up since then, the relativity to them is they're all weird. Mm-hmm. They're kind of these outlier topics. Granted, I can find something to associate mental health wise, like for example, death notifications. There's an association with a lack of training and burnout. And then with CPR-induced consciousness, a lack of support and awareness and education around what to do, and moral injury. So they're all kind of relative in a way, but ultimately the common theme between anything I teach is that I just find it interesting, and it's kind of an outlier topic that isn't at the center of most people's minds. So like CPR and high performance CPR might be at the center. Well, you've got death notification, CPR-induced consciousness, Lazarus, and these are the things that are on the marginal side, which is also very on par with depth psychology. Depth psychology goes to the margins and asks, what are we not paying attention to? What's not so obvious?
So with that, with the talk of things that are on the outside ring, I am not familiar with this concept of the Lazarus effect. Can we talk about that as we get to things that I'm more and more familiar with and the kind of things I want to talk to in your purview? Explain to me what the Lazarus effect is.
So Lazarus effect is actually a little different than Lazarus phenomenon. If you've ever had a patient that, I don't know, like when people, this might not be as applicable to EMS, but let's say in hospice care, when a patient is terminal and they officially, die basically, they might have some movement, and that's considered the Lazarus effect, as the body's nervous system is kind of shutting down, as muscle is discharging its last of its, reflexes. Maybe they have some gases exchange and they finally let out some air that's trapped in their lungs on their last breath, kind of thing. That might be very loosely referred to as the Lazarus effect. Lazarus phenomenon, also more appropriately known as the auto-resuscitation, is where a patient is resuscitated, they're in a cardiac arrest, there's a resuscitation attempt, and it doesn't work for whatever reason, and they terminate resuscitation, and they walk away, and the crew is hands off, the medical team is hands off, and all of a sudden, because they're either walking out of the room, coming back in the room for something, they notice that the patient's moving again. And they now have essentially auto-resuscitated themselves without the help of any intervention for whatever reason. We don't know why. We don't understand it. It's a very, very, very rare occurrence. And there's many cases of patients who walk out neurologically intact regardless, despite that.
So when you say very, very, very rare, are we talking like 3 instances ever, or like what's very rare?
When I did the course, I think I had 78 identified case studies.
Wow.
There's not many. There's very few. And on top of, now, here's the tricky part with things like this, including CPR-induced consciousness, is there is no check mark in your CARES report to say patient auto-resuscitated, right?
Yeah.
Patient woke up while I was giving compressions. Like, we're not even looking for this. So we don't have an idea of how often it happens. And then on top of that, if this happened to you, last thing you want to do is tell people. You're like, where did I mess up? There's a lot of shame associated with that, and this risk and fear of failure. And people have gotten in trouble because there was one case where a physician was, the family wanted to sue for malpractice because this happened to their grandfather or something like that. And he was able to prove that this was a case of auto-resuscitation. He showed literature of this happening and so forth, and he was able to clear his name. But again, it's a rare phenomenon. It's just an interesting one. This happened, let me back up a little bit and say that this happened to somebody. I worked as an EMS coordinator, and this happened to one of my guys, and he called freaking out. And he's understandably so, he's like, this guy's 78 years old. I promise you, we did everything. We had him on the monitor 25 minutes. They only needed to do 20. He hit all this criteria. We terminated the resuscitation. He, under certain circumstances, you didn't have to call the hospital. And he goes, and we told the family, and we cleaned up everything, and we're going to put everything in the cab. And sheriff walked out and said, "Hey, buddy, you're not done yet. Like, he's moving." And they walked back in there, and he's got a pulse, blood pressure, spontaneous respirations, whole thing. And he's freaking out. And I said, "Well, did you leave him there?" And he goes, "No, we took him to the hospital." I said, "Okay, then document that." But he was panicking because he immediately thought he did something wrong.
Yeah. I mean,
understandably
I would imagine,
so.
I mean, that's...
And people do make mistakes, but this was not that, because I went back and I looked at the Zoll data. Guy was in asystole. He had low end-tidal CO2, never had a change. I mean, he was dead.
Have they... I have 2 questions about it. I'll hit you with both questions. You can answer it long form. How much of a, I guess, I don't know what the right word would be, refractory? How long of a period of time since ceasing CPR to these people coming back have been kind of documented in this? And then there's no like pathophysiology that they can track to connect the dots between these things that says, this is glucose or end-tidal or sodium bicarb delay or whatever the heck it could be to cause something like that.
There's a couple of working theories.
Yeah.
There's a couple of working theories. The most, I would say the most substantial one, that's not just like, it's idiopathic. I mean, really at this point, nobody really understands it. But there's a theory that maybe it could be caused by overventilating the patient, which we know happens often, and that maybe the pressure puts too much pressure on your vasculature so that you can't actually palpate anything that's happening, and that maybe it prevents spontaneous return of circulation. And when you stop working on them, it allows that pressure to equalize and then reinstates the heart. That's a far-fetched theory, but
even with asystole rhythm, like not like a PEA or something like that, like with an asystole rhythm, it would come back just from a decrease in like.
That's the best that they got, right? It's a theory.
Huh.
Now, the other half of your question was how many minutes on average. So there's a couple. Like, there's been people that weren't identified. Like, there was one woman in Poland where she was expected to die. She died at home. They had a living wake, like where everybody came to say goodbye to her. The family physician came. He checked everything head to toe and signed off on the death certificate. She was certified, like per the paperwork, dead. and they discovered her in the morgue like 12 hours later, alive. But so technically, was it a 12? She wasn't literally dead for 12 hours. She was unaccounted for like 12 hours, let's say. And she woke up craving pancakes and tea. She was like, I'm cold.
My God.
Luckily, she had dementia, so she had no idea what was happening. She had no idea what was happening.
I can't even imagine the amount of bodies I've pronounced at this point in my career, but every single time I do it, I'm terrified they're going to move. I know. I don't even know. It could be like the most modeled, bloated, rigored person of all time. When I go to put stickers on them or to do something to touch them and verify, I'm terrified they're going to go, gotcha.
But generally speaking, it's recommended because the average based on monitor time is about 7 minutes. So the some of them are as early as 30 seconds to 2 minutes. Some of them have been a good 15 minutes. So what's recommended is that you passively monitor them for 10 minutes. So meaning, let's say you terminate a resuscitation, you still got to talk to family, you got to clean things up. Maybe you have to wait for law enforcement to hand over the scene. It just depends. So what's recommended is that you just leave them passively on the monitor while you take everything else aside, is one way that you could.
And I'm sure they're not all the same story, but typically they're converting back into a sinus rhythm, or are they going into like a shockable rhythm or something like that?
They look, most of the cases that I've read through, they go into a sinus or sinus tach.
Wow, yeah, that is crazy.
Here's the best one. Let me tell you this story. There was a case in the UK. There was a young guy, 21 years old. He's at a rave. He's doing ecstasy, heroin, cocaine, goes into respiratory arrest. They call paramedics. They give him Narcan. They bring him out of it. And he ends up going to the hospital with them. And en route to the hospital, he goes into asystole. They start working him up. They've got no changes. They're giving him epi. They're doing all the things. They get him to the hospital. They continue working him for a period of time. They get absolutely no changes on the monitor. They go, we've done everything we can. We're going to terminate this resuscitation. They cover him up. They walk out. And then the nurse comes back into the room to get something and notices an organized rhythm on the monitor. Calls the code back up. They start treating him. They get him ready to go. They stabilize him. They get him up to ICU. He spends 2 weeks in ICU. He's got pneumonia. He's got 2 or 6 weeks, but he's got pneumonia. He's got sepsis. He had something else going on, and he walked out neurologically intact after being pulseless for that long.
Wow.
He was unaccounted for about only like 2 minutes though. So, but however much time from them to stop ventilations to then restart them and him being neurologically intact is wild.
Yeah, the human body is so bizarre. How that's one of the things I've like learned, in my time working in, EMS is like, there's no sense to it. Early on, I wanted to make sense of it, like why some people lived and why some people died. And then at some point you go, wow, it really sometimes does feel like, the movie Final Destination. You're like, well, I guess this person it was their day. I don't like, and then some person has a way worse thing occur and then they're just like fine. And you just have no explanation of why.
Oh yeah.
It's total chaos.
I want to be very clear that I share this not to sensationalize and scare anybody into not terminating. I'm a big believer in that terminating, work people up on scene, terminate them on scene, get that grieving process started, let the family see what you did with, there's always exceptions to that rule. But rather, if this does happen, God forbid to you or to somebody that you work with, that that there's a possibility. Like, some people make mistakes. Sometimes it is human error. Okay. Sometimes people don't. There was a very questionable case that happened in 2020 where they failed to double check when the mom said, I think she's still breathing. And they said, oh no, that's just epi. And they dismissed her until a neighboring city had to go respond to the morgue where this girl was very much still alive.
Yikes.
Right? So mistakes do happen. I would be hard pressed to call that a Lazarus phenomenon or auto resuscitation. Or if it was, there were some errors in the procedures that took place after that, right? But my point is that if this does happen to somebody, the last thing I want them to automatically think is it's my fault. Like, let's objectively go back to the data. Let's look at our steps. Did we do everything possible? Go back and look at this old data or whatever, device you have and double check. But sometimes it does happen and it's not the provider's fault, and people should know about that. So that's why I like talking about it. On top of the fact, I just find it really fascinating.
Yeah, it's very interesting. Wow. So the next thing I want to talk to you about is CPR-induced consciousness. And we talked about this a little bit before we started recording, but I literally went to one of these yesterday. Like yesterday evening around dinner time, I went to an arrest that had CPR-induced consciousness. And I was like, wow, I'm planning to talk to Alex tomorrow. This is crazy. And the person, fortunately, we got Rask on scene. They were talking by the time we got to the hospital. It was awesome. But it was interesting for a couple reasons. I've seen it before. This one was, very strange. They were like eyes wide open, obviously making eye contact, alert to the environment. When my captain drilled the IO, they moved, like their leg moved, which was like, whoa. Like my captain said, I had a feeling we were going to get him back when he moved his leg when I drilled the IO. And we're like, and he was still in VFib, pulseless. And
how old was he? Or like range, lower, younger?
Elderly.
He was elderly. Okay.
Young elderly, I would call it, for the sake of HIPAA.
Okay. Oh, yeah, no, that's why I asked,
you're fine. It was, and we had a rider with us, first ever cardiac arrest.
Oh.
Yeah, and she did wonderful, but I was like, first off, the thing I told her was like, maybe you should just retire right now. Like you could walk away with a perfect save percentage. Like you could just like be like, I don't know why you guys are making this thing so hard. I mean, I did one and we saved him and it's fine. But talking to her about that concept of like, yes, he was with us, but it wasn't his body function that was causing it, as bizarre as that is to see. As then he eventually got Rosk and then he was talking to us, then it was like, this is a different thing, you see, right? From what we saw while he was on the Lucas device to now him, running his own body system to create that consciousness is a very different thing. But a couple things I have questions about to you is like, the big one is, well, what is the purported experience of these people that have this, then return to Rosk and then have no neurological deficits and can tell their tale? What is their level of awareness during these situations?
It depends. There are people that have had reported CPR-induced consciousness during their arrest that are alive to tell it today, that are able to tell it because that's what was reported to them. They don't have any recalled memories of it. Whereas there are people who have had CPR-induced consciousness, which if your listeners don't know what it is, it's where the CPR quite literally induces the consciousness in your patient. So when the compression stops, so does their sense of consciousness within a few seconds afterwards. So it could be up to 15 seconds after compression stop that the patient stops exhibiting signs of objectivable, consciousness. And it can range anywhere from, moving when you have painful stimuli, to being purposeful movements, to resisting compressions, to tracking and looking at providers, to having full-blown conversations while they're in a cardiac arrest receiving compressions. The most common presenting rhythm is VFib, VFib or VTAC, pulseless VTAC, but it has been reported in confirmed PEA, so having an arterial line or some sort of secondary bedside assessment to determine that the patient's heart is in a cardiac standstill when compressions are stopped, and asystole. It's more common in men. It's more common in younger men based on what we have. We have very limited data, actually, though. So then I did hear, though, and I think this is okay to share because he put it in the comments, but I haven't heard back. We're in the middle of a conversation right now. There's a surgeon, he's an OBGYN surgeon, who had a cardiac arrest himself and had CPR-induced consciousness during the cardiac arrest, remembers it, and he emailed me just a few days ago to tell me the story.
Wow.
And he said that getting defibrillated, and his surgeon, so he was in the middle of surgery himself, and the surgeon apologized to him and said, I'm so sorry, I don't have time to sedate you. And he said getting defibrillated felt like getting struck by electricity and kicked in the chest by a horse at the same time. He said it was the worst pain he's ever felt in his life, but that he appreciated that surgeon for acting as quickly as he did, because he attributes that to why, he's still alive today.
Wow. Are there any purported near-death experience like situations like that while they're in this limbo of life
that's
or
a
death?
whole other phenomenon. That's a whole other phenomenon, and I do have a class in that. It's not online yet, but that is so near-death experiences is what it's historically been called. More recently, they've kind of rebranded it to be a little bit more palatable to the medical community, because NDEs have been highly associated in religious and spiritual kind of realms, and that, those things mix like oil and water with medicine and science. And so they've kind of rebranded it with the term recalled experiences of death. And Dr. Pernia out of the Pernia lab in NYU has done extensive research for about the past 30 years, but more notably in the last 10 years, they've published the results of the AWARE-1 and AWARE-2 trial, where essentially the difference between these two is that you have patients that were in a cardiac arrest that show no signs of consciousness observed by the provider, but they survive. And after the fact, they go, oh yeah, I remember you doing that. I was floating in the corner of the room looking down.
Oof.
Yeah. So that is a type of cognitive awareness, whereas you're conscious, you're aware of self, and you have this experience while you're dead and you live to report it. That is different than CPR-induced consciousness. That is completely different. So it's unbeknownst to the provider. So I always tell people, and I teach this, please always mind your P's and Q's, because up to 10% of cardiac arrest victims that survive have recalled memories of the event and what you did while they were in arrest.
Oof. Wow, that's crazy. Wow, that is crazy. So
and that's
the
published. That is published by the legitimate sciences and NYU and all this stuff like that, and as well as the University of Virginia has done quite a bit on that. So,
do you have any relationship with that guy?
We're on LinkedIn. I've messaged him because there was something he said in one of his papers that I had some questions about that I didn't quite. I was like, I don't think I agree with that. And he's like, he was really cool. He was like, you should write a paper to essentially disputing it. And I never did. But yeah, he's accessible on LinkedIn, Dr. Pernia.
I was gonna say, now I'm gonna have to talk to this guy.
You should.
That's very fascinating.
He presented at the AHA conference too.
The other thing I want to talk to you about with this, the CPR-induced consciousness is the ethics of it. So I'll paint the situation to you and you tell me what your thoughts on it is, which is we have a patient that we're more or less confident based on the vital signs is not going to survive. While they're on Lucas or whatever CPR method we're using to induce consciousness, they are aware and obviously alert. When we cease medical resuscitation, what's the ethics of that? What's the medical duty versus ethical duty to that person?
That's what makes this such a messed up topic. So just so I don't confuse your listeners, we were talking about cognitive awareness, recalled experiences of death while the patient is in a cardiac arrest that's unbeknownst to the provider. Now we're back to CPR-induced consciousness, which is that the compressions are inducing the consciousness of the patient. And there have been cases where everything was done and nothing more could be done. So for example, there was one case in Northern California where the patient was the recipient of a heart transplant. There was nothing else they could do for this guy. The heart transplant failed. He was not a candidate for another transplant. And he literally said, please stop. He terminated his own resuscitation. He's like, I'm done.
Wow. Holy cow.
He told them, I want to be done. And they had to stop. But here's the thing is, if you have a patient that is presenting with CPR-induced consciousness, that is presenting with purposeful movement or, being able to consciously respond to you, that is a high indicator of survival. their brainstem is still intact, the perfusion, they're not going to have an anoxic, they're less likely to have an anoxic brain injury afterwards. It is recommended that you extend your resuscitation attempts by up to 40 minutes plus. So from 20 minutes to up to 40 minutes. So for me, it was always more traumatic to have a patient that was talking to me that arrested in front of me and then they died. I can't imagine having somebody that was alive and talking to me during the arrest and then having to stop like that.
Yeah.
I feel like would leave a really big mark.
Yeah.
And so what you're touching on is that it puts the provider at a higher risk of moral injury potentially. Because then on top of that, go ahead.
And how do you possibly explain that situation to a family that has like little to no medical knowledge of what they're even looking at? Right?
How do you explain that to somebody who doesn't know what can happen?
To kill their mom or whatever, right? That's
It's hard, and it's even harder if you didn't have an awareness of what it was as the provider. Much more confusing. I mean, there's a number of people, I've talked about this several times over, on my Instagram or TikTok, and there's so many reports of people saying it was so traumatic. We had no idea what it was. The first time I saw this, we were so confused, or thank God our attending knew what it was and knew what to do. But there's been multiple times where they just don't do anything. They don't give any medication because then they're worried about the hemodynamic conditions or the consequences of giving midazolam to sedate the patient that, which there's some proof to suggest that a patient who gets certain medications takes longer to achieve ROSC, and it's not associated with better survival rates. So it's kind of like, do we, treat the condition right in front of us, even though it might risk us getting, the patient to survive? Do we, what do you do? And it's a lot to weigh, especially if you've never even knew this was a possibility. And there's a lot of people out there that still deny it could even happen.
Yeah. I mean, if they do, I can tell you as of 5 p.m. yesterday, I was watching it with my own eyes. So if you trust me, I for whatever that's worth, I saw it yesterday, and I've seen it before, but yesterday it was especially impactful knowing that I was going to have this conversation with you today. So I do want to touch on death notification. We're getting to the point that we're going long, which I'm very happy to do as long as it's okay with you. But I would be remiss if I didn't at least talk to you about the death notification thing, because I do think it is a vulnerability inside EMS. It's a difficult thing to do, especially for someone the first few times they do it, or for even an extended period if you're uncomfortable with it. But yeah, I'll tell you the story quick, an abbreviated version of it, because I know this is kind of a somber subject in some ways, but man, do I have a story that tickles my fancy about a death notification I was a part of. And for those of you who are not inside this community, I apologize, because the humor inside of the first response world is a little bit different. But man, so we got called for a welfare check. It was my crew, 4-person crew. We arrive in the lobby. We meet up with someone who purports to be the occupant's nephew. And he says, my uncle is kind of flighty. Sometimes he'll just like pack up and be gone. Like he'll just be gone. And, I don't know, I'll find out he's in Chicago or whatever. And so he keeps saying this phrase, my uncle's sometimes gone, like all these things. And so we get up to the apartment. He opens the door and we're like, hey, we'll check it out. We'll let you know. And so we go inside, me and my partner and my captain, and we find the gentleman deceased on the bed, obviously DOA. And we come back out to the hallway, and God love him, my captain goes, he's gone. And the guy goes, oh, and he goes, and he stumbles on his words for saying, by gone, I mean dead. And it was like, oh no. And like, I had to like bury my head in the sand and walk back in there, because I was like, I'm going to lose it, because that was an absolute shit show. And he ended up being, my captain's a wonderful dude. So he smoothed it over and did it. But man, in that moment, it was a big discovery for me to realize, man, very specific words matter a lot in that conversation, because the fact that he chose the word gone to a different person might have been understandable, but in that person's mind, gone meant, oh, he's in Chicago maybe or wherever. And when he said gone, it was absolutely not dead until he said by gone, I mean dead. And then all of a sudden it was a nightmare.
Well, what's interesting about that is that he had a history of being flighty, like he said, so he's automatically going to go there. But if you think about somebody who is, if they're calling for a welfare check, they know that it could be nothing, it could be everything, right? There's a spectrum. Yeah. And if they want to go straight to denial, they're going to go, well, where did they go? Almost anyone is going to think, where did they go before they think dead?
For sure. Yeah. And like I said, that was a wake-up call for me in this process because, as a firefighter, not someone that's typically doing these death notifications. I've been there for a lot of them, but that was an eye-opening experience to me. Like, wow, these words that we say in these moments need to be chosen carefully because just a couple missteps and you can have a whole different message than what you were anticipating that you were conveying. And I think
we lost them. Where did they go?
Yeah. And now since then, our department fortunately has put us through some level of death notification training, which has been good. But at that point, that was not the case. So with that, walk me through your understanding of that and some of the missteps that the career field's taking and what we can do to do better.
We need training. And I say that knowing I do have a training course. I don't care whether people go through my training or not. I just care that they get it. That's the big push that I have set out to, create a wave in doing for the past several years. I'm grateful that I've had the platform to do that and that the community has given me their attention so that I could do that. Otherwise, I'd just really be talking to myself. Saying the words dead and died, we have to recognize that in social settings, as Americans, it's perfectly acceptable to say passed away. If we were talking about, my mom passed away when I was 18, no big deal, right? You don't have an emotional attachment to her. This isn't an acute setting. This isn't in an emergency. And we're not in a professional dynamic right now, right? We're just having conversation. Say passed away, that's okay. Any other time, when you are in a professional setting, you are acutely delivering grave news, you have to say dead or died. Very rarely does anything else land. And I've got hundreds at this point, hundreds of comments from the layperson, which I'm so grateful for. In Instagram, I get a lot of people in our industry. On TikTok, I get a lot of responses from the lay people, and they have testimony after testimony after testimony. They weren't clear with me. They kept dancing around it. They said that they lost her, and I thought, where did they? We'll go get her. They said that she's gone. Well, where did she go? Like, just the clarity, the lack of clarity comes up time and time again. They confuse me. They caused unnecessary suffering by wanting to avoid the truth with the patient's family members. So lean into that and know that you could, just like you could do everything right and the patient still dies, you could do everything right in being clear and compassionate and kind, and the family will still fall apart. Because the point isn't to circumvent and prevent them from grieving. That's not the objective. And you're going to walk away potentially feeling like you did a bad job when in reality you didn't. You gave them space to fall apart. You gave them space to start that grieving process. And grief is very messy and it's very uncomfortable for us, but it's very necessary for them to heal.
I think that brings up another thing that is always a source of discomfort in this process is, so the death notification happens and then the family, falls apart to various levels depending on how it's taken or expected. And then there's this moment of like, all right, we just told you this. You're super sad. We kind of got to leave. What are the pros and cons of a rapid exit versus a long goodbye, if you will?
I mean, that's hard to say. The fire department was on scene for about, I want to say 2 hours after our mom died, maybe longer than that.
Wow.
Because she was, and in my 18-year-old state, I was like, oh, how nice of them. Like that they would, on a hot day in August, they would choose to hang out with my family and be here for us. They weren't talking to us. Like two of them were on the tailboard. One of them was with, walking in and out of the house. The other one was doing whatever. The ambulance had already cleared. And I felt taken care of. I felt sought after and the support without any direct engagement. I later found out, in hindsight, once I understood the system, that she was a coroner's case and they were waiting for law enforcement to clear them. But even though I learned that after the fact, it didn't make 18-year-old me feel any less taken care of. And so I remember that perception.
And I think that that's what gets complicated, because I don't think it's necessarily always we want to leave and get back to doing something else, but there is this kind of, sacred space. I think you kind of referred to it as earlier. And I almost feel guilty being there while they grieve their lost loved one that I have no connection with and emotional attachment to, right? It's like, it's like the slow exit to the door, but then also you feel like, all right, bye, see you later, which is also kind of cold, right? Yeah, like, all right, we're going to go eat dinner, bye, right? So I don't know.
Your job there is done after you deliver after you attempt to resuscitate or you deliver that notification and you notify the next authorities, because sometimes it's going to go to law enforcement, sometimes it's going to be released to the family so that they can call, the mortuary, wherever it goes from there. And the most you can do, the best thing you can do is, if they don't already have family there, is ask, who can I call to come be with you? And you pass it off to them at that point.
Yeah. So when we think about these processes that have been kind of developed as far as like the warning shot and like the, all the things that come along with these properly given death notifications, are the positive outcomes that come from this data driven or more like experiential, as saying like this seems to work better, or is there actually any tangible data that says this is better to this degree for this reason?
Well, it's all experiential. Even the data that has been published, there was a really good study. I was actually just looking at it recently that was, I don't remember when it was published, but it doesn't matter. And it talked about how the very clear notifications really made them feel, it put them at ease, it made them feel cared for. It was like a proper way to deliver that. It's being reported based on the survivor's opinion, based on the survivor. So it's all experiential. It's all anecdotal, right? It's all we have to go off of. There's no way to quantitatively measure this without including the qualitative data of the person's anecdotal experience. And so that does get reported back time and time again, that they need to be told very clearly, on top of the fact that you talk about cultural diversities and language barriers. Other countries and other languages don't have euphemisms like we do for dead. You have to say dead and died, or let's talk spectrum and autism. So you've got neurotypical or neurodivergence that you have to consider, where you have to be very clear about what the patient is and isn't. And it's not that they're lost. It's not that they're no longer with us. It's that they're dead.
And when we see these outcomes, say, more quote unquote positive experience in a properly given death notification, are these primarily talking about the outcomes for the survivors, or what about the outcomes for the responders in giving a death notification correctly versus incorrectly?
I don't think that part has been studied yet, not to my knowledge. What I do know about what has been studied about responders is that 5 or more death notifications given in a 12-month period without training was associated with a 73% greater odds of burnout.
Wow, that's pretty significant. Holy cow.
Huge. And the anecdote was training. So providers who had received training, not just in their initial licensure, but in continuing education. So my perspective, my philosophy is we should get death notification training as a primary in EMT school, paramedic school, and then we should be revisiting it, even if it's just a module, every time you practice CPR. So if you're an agency that does quarterly training or annual training or every 2 years, like the AHA, there should be a part of that course and that recertification that we talk about death notification training. Have a ethical dilemma, practice it, talk about most recent experiences with the people that are in the room, share your own failures, and let others learn from that. And, you know, I put a lot of resources up online. They're always up for grabs. So take them, use them, apply them. And it's one of those things that, that the anecdote being training was found to reduce that risk by about 24%.
Wow. Holy cow. Wow. Well, that's significant enough. If that's not a reason to dig into death notification training, I don't know what would be then. So with that, obviously I appreciate your time here today. Tell our listeners where they can find more resources about these topics from you, where they can find your socials, stuff like that.
You can find me online pretty much anywhere, Emergency Resilience. I am the most active on Instagram, and we like to have a lot of conversations there. I don't post a lot in my feed, but I'm almost always yapping about something in my stories. So I invite you to have conversations with me, share your experiences. Everything is always anonymous. And if anybody shares anything that's really specific, I ask, I take extra caution and ask permission to share things anonymously, just to always keep that, that standard that this is a confidential space to be open with our discussion about things.
Awesome. Well, thank you again for taking the time to talk to me today. I appreciate your expertise, and I appreciate you taking the time to talk to me.
Yeah, thanks for having me.
Of course.